Thanks, Ernie, for the opportunity to speak with everyone today. What I wanted to do was take roughly about 40 to 45 minutes or so and go over, first from a high-level perspective, what we're seeing in the marketplace from an audit and review perspective. Secondly, review some of the specific auditors, because not all auditors are reviewing their processes in exactly the same way or looking at the same issues. And then finally, go through and talk about what are the best approaches to each of the individual audits and how to set up this RAC Rapid Response Team as we're going along. So on slide number 2, I think regardless of which auditor that you're speaking about, a very good starting point is trying to identify and isolate, okay, while the patient's in the hospital, what are the cases that are at high risk, high probability for focus and review? And if you look at these two circles as being the total number of patients that come into the hospital on a regular basis, the majority of these cases are straightforward, and what I mean by that is there's cases that are obviously inpatient, patient who has a heart attack, patient that needs open heart surgery, patient that has a respiratory failures on a ventilator, and those are not the cases that the auditors are going to be focusing on and targeting. On the other hand, there is the cases that are clearly outpatient, scheduled transfusion, minor procedures, and things like that. For the most part, what the auditors are focusing on a day in and day out basis is all of those borderline cases or gray cases, the cases that don't really fit neatly into one of the criteria sets, the cases that can kind of go one way or the other depending on the clinical scenario, the comorbidities of the patient, and other factors. And those are chest pain, syncope, dehydration, and particularly cardiac procedures on the surgical side. On slide number 3, one of the things that we're seeing is that the gray zone or these borderline cases are increasing, and they're increasing for a number of reasons. One of the big reasons that they're increasing is being driven by cardiac procedures, in that several years ago all of the cardiac procedures were on the inpatient only list, and as medicine has evolved, as medicine has gotten better, these have the outcomes have been better, and so some can be done on an outpatient basis, so it's not required that all are being done on an inpatient basis. We're getting ready to see this, the exact same scenario play out in the orthopedic world, particularly with knee replacements, and this is where, well, not all need to be inpatient. Some can be inpatient, some can be outpatient, and it's just a matter of being able to differentiate those out. So this gray zone is not just increasing in the medical world, but it's also increasing in the surgical world as well. On slide number 4, it's important to remember and understand that the target areas that are being focused on, there's been a natural evolution from coding and billing over to medical necessity, and the medical necessity is essentially inpatient versus observation, and this is going to be the primary focus going forward, given that it is very difficult to fix medical necessity. It really comes down to improving documentation, and that's not the thing that's very simple or straightforward. As a side note, one of the other areas which is starting to pick up a lot of steam by a few of the contractors is indications for a procedure, or essentially LCD versus NCD. And that's not a should this have been done on an inpatient basis or an observation basis. This is, was the procedure appropriate? And that's kind of a whole nother discussion for another day. On slide number 5, unfortunately, what we've been seeing is that there has been definitely more aggressive behavior by the contractors. And if you look at the environment overall, for the most part, the regulations haven't done any major shifts one way or the other. Procedures in medicine have not changed, or there haven't been major shifts. It's not like we have a blood test for chest pain which is automatically be able to 100% rule out a cardiac etiology or rule in a cardiac etiology. It's still a clinical judgment case. And so what we have absolutely been seeing is how the regulations have been interpreted by the contractors. And this is probably a really critical point for providers, in that if a contractor applies the regulations and the criteria incorrectly, and the providers don't challenge those, or they just roll over, then you've essentially set up a new interpretation, and those new rules then now exist. So it becomes very important to know the regulations, know the standard, but also ensure that you stand up for yourself and say, okay, this is the process that we're going to follow. On slide number 6, probably one of the best examples is the use of screening criteria alone. And it was